So, welcome everybody and good afternoon. Thank you for joining us today at this webinar organized by EURO-NMD in collaboration with the European Academy of Neurology and EURO-NMD for rare neurological diseases. This session marks the fifth episode of the EURO-NMD webinar series, Management and Treatment of Myopathies. A little presentation of our speakers today. So Professor Peter Young is the medical director at the Medical Park Baden-Fenbach, Reithofpark, Germany, a specialist in neurology, sleep, and intensive care medicine. He previously led the sleep medicine and neuromuscular diseases department at the University of Munster, where he was appointed professor in 2008. President of the German Sleep Society since 2024, his research focus on neurogenetics, SWAN, cell biology, and sleep disorder in neurorehabilitation. Thank you very much, Professor Young, for being with us today, and the floor is totally yours.
Okay, thank you, Elizabeth. Thank you for introducing me so kindly. And hello, everybody. As Elizabeth said, I'm a neuromuscular specialist, and I focused a bit my talk today, not just on myopathies, but because I actually wanted to give you some more of the general aspects, which what we can do from a non-pharmacological aspect in neuromuscular disorders. So I will also go into, I won't go into too much into dissect or separate disorders, but I will give you some aspects and ideas what can be done in neuromuscular disorders from a point of neurorehabilitation, which is actually combining all the non-pharmacological aspects of treatment in neuromuscular disorders and myopathies. So, okay, so my agenda will be so that I will, on the one hand, will look for the assessment for patients with neuromuscular disorders. Then I will talk about impairment-based therapy and rehabilitation, so actually combining all aspects of non-pharmacological treatments like physio, occupational, speech therapy, breathing therapy, and so on. Then I would go for what kind of evidence do we have for non-pharmacological rehabilitation in neuromuscular disorders? And then I will give some just to introduce you a bit in the international classification of functioning and what I understand of personalized rehabilitation. So when we think about neuromuscular disorders and non-pharmacological treatment, so actually what is actually could be summarized in the aspects of rehabilitation of neuromuscular disorders. So what can we do on supportive therapy, actually all done with the combination of treatment like physio, occupational speech therapy, then we have to be aware that, of course, the neuromuscular system has special aspects or different aspects. So on the one hand of the nerve, or what is neural atrophy, diseases like amyotrophic lateral sclerosis, neuritis, or polyneuropathies. On the other hand, we have the big group of muscle diseases, myopathies, myositis, muscular dystrophies, and myotonia. And of course, the third group would be the nerve-muscle connection aspects, the end plate diseases like myasthenia, Lambert-Eaton, and myotonia. So, of course, when we try to figure out what is the best what is the good combination of non-pharmacological treatment in neuromuscular disorders, we have to face that we have this big variety of different diseases. And even just myopathies is a big variety of different diseases, different pathophysiology, different basis of the disease. So for that reason, I want to try to figure out some aspects which give you an idea what rehabilitation research could mean and imply. So on the one hand, we should look for the aspects of basic research, genetics, molecular biology, cell biology, animal models. I just picked here out 2 mice on treadmill from my very former research where we produced or tried to create animal models on Charcot-Marie-Tooth disease. Of course, the other aspect is the clinical research, clinical trials, clinical application, convalescence, and rehabilitation aspects. So what we know from other parts of this disease and neurology, that actually the translation of basic research into clinical areas would be very good, or would be an aim to follow. On the other hand, we know, especially for the aspects of non-pharmacological treatment, so what we see in rehabilitation, we see that there is a very, very even little and much less than in acute therapeutic approaches, pharmacological approaches, which are really translated from basic research to clinical research. These are just some aspects which I ask you to think about, because we know that we also see in animal models aspects which could be wonderfully translated into non-pharmacological treatment, but mostly we lack and we do not do this. There are several aspects why this is not there. That is funding, the lack of funding, but also the lack of intellectual, scientific, proper questioning for these diseases, which is, for example, I'm from Germany. In Germany, we have really, really little research on non-pharmacological treatment in neuromuscular disorders. So this was just to have a kind of assessment idea. And so when we go on in the aspects of what could be, how to approach a patient on the aspect of rehabilitation. So what can be done? And I want to figure out 3 examples. So on the one, Pompe's disease, spinal motor atrophy, and Charcot-Marie-Tooth disease. So actually one myopathy, 2 neurogenic diseases, just to show you the overall differences of symptoms, of aspects which can be treated. So Pompe's disease, alpha-glucosidase, the GAA deficiency, a very rare disease, autosomal recessive with proximal paresis, diaphragmatic palsy. Survival, so SMA caused by the genetics in survival motor neuron gene, also a rare disease, autosomal recessive distal proximal paresis, and also in the end, and very often diaphragmatic palsy. And CMT, a much more frequent disorder with more prominent distal paresis with sensomotor deficits, mostly autosomal dominant, and distal paresis are actually the focus of the disease. So when we see, and all these groups, possibly you have seen patients with of all these 3 disease groups, you know that there can also be different phenotypes within one of these groups. And for that reason, I don't think that it is important to have a specific disease-related non-pharmacological treatment, but more treatment which is dedicated to the impairment. And that is what we call impairment-based therapy. And what are the aspects? So on the one hand, we have the areas of deficits which occur in the framework of the neuromuscular disorders, like transfer, standing, walking, use of arms, manual use, speaking, swallowing. These are aspects. Breathing could also one of these aspects. And for that aspect, we have often additional aspects like physical requirements that must be present for this. So perception, you need power, you need perseverance, coordination, and compliance. And if we look at up from the example of Charcot-Marie-Tooth disease, so where we have a distal disorder with atrophy, with peroneal wasting of muscles, with foot deformities, we see that this could one aspect where the impairment we could focus on. So how to improve gait, foot to reduce foot drop, to reduce foot or to improve foot function. This is one aspect of clinical picture to get to know what impairment we have to focus on. And just to see this, what are the studies? There are some studies, and in the last years there comes many other studies come up, but just to show that we start having studies on rehabilitation on Charcot-Marie-Tooth. For example, that we focus, we try to figure out how much we have, and I did one twice Cochrane review on tooth disease, we know that there is literature on non-pharmacological treatment of this disorder, rehabilitation, physiotherapy, management, and we can figure out that there is studies focusing on this disorder. But in the end, we actually see that we want to summarize and get clue out from the literature, we see that also literature is much more focusing on impairment than on disease per se. For example, here, this from the Italian group, where we see that possibly rehabilitation of hand function is an impairment aspect. And what we see, if we just see like a tripod pinch with the hand, so we can figure out, and hand grip, that this impairment can be improved by rehabilitation if we look on specifically impairment dedicated hand program from the aspect of occupational therapy and physiotherapy. And this is what I wanted to stress here, so that impairment has to be defined and treatment has to be specifically tailored to for the rehabilitation of this function. And this is very nicely shown in the last years in the CMT field, so that we actually have to be much more turn our focus to the impairment than on the disease per se. And this is one of the messages which is very important for non-pharmacological treatment. So we have to figure out which impairment is the focus and the aim to improve in our non-pharmacological treatments. Another thing could be gait function in Charcot-Marie-Tooth disease, which is disturbed by foot drop, by peroneal atrophy, by sensory loss. And if we look and try to figure out that gait function by, for example, treadmill therapy could be one of the aims to improve, or could be to improve gait function. And if we figure out it properly and tailor our non-pharmacological treatment exactly on this aspect of function, of impaired function, then we will also be much better and much easier see that there is also, if we do then the right outcome measures, like for example here with the SF36 in this paper by Mori et al., we see that if we do it properly, then we can also figure out improvement in these aspects of impairment tailored or based therapy. As here, for example, physical activity could be improved in this group as a specifically sorted out impairment in Charcot-Marie-Tooth with the tailored therapy here in this treadmill training. So in overall, sorry, the flow chart here is in German, but it's actually much more to show that we have to look for different aspects of impairment. Like this is breathing, swallowing, paresis, endurance, standing, and sensory system. And then we can tailor all our non-pharmacological therapies, breathing therapy, speech therapy, then speech therapy, specific swallowing therapy, or improving to swallow. For the aspects of paresis and deficits of power, of strength, we have, of course, many different aspects of physio, sport therapies, power endurance, riding training, and so on. Also for endurance, especially treadmill, Nordic walking, all these aspects could be seen as non-pharmacological treatment in neuromuscular disorders, as in myopathies, as in neurogenic atrophies. This is also, and this is actually the reason why I also wanted to show you that, of course, we have in neuromuscular disorders not only functioning of muscle function, but also sensory function, and we also need to tailor our therapies, on the non-pharmacological therapies, on the aspects of sensory loss, of paresthesias, loss of sensation, and so on. So that's actually how we should work and should do the composition of therapy units dedicated to the impairment which is caused by a disease. Like here, my first example was Charcot-Marie Tooth disease, but it would be the same difference that you either dissect proximal myopathies from distal myopathies, from end plate therapy, end plate diseases like myasthenia gravis, from possibly CIDP. So actually, but in the general, you could have groups with the same impairment with totally different causes on different diseases. And for this, actually, this is what was very nicely done in the group of Reithofpark several years ago, so that the implication of rehabilitation here just exemplified by Charcot-Marie Tooth disease, but could be a wonderful example for other diseases as well, that on the one hand, you have to see what kind of deficit is there, what kind of impairment is important, what is the deficit, the impairment is specifically caused by the disease. And on the other hand, you have to look in how far aspects of frequent series of programs should be used and should be applied to improve a patient beyond pharmacological treatment, which is actually specifically then, because I was so general now, of course, this could be then, should be done in a structured way. And one of the structured way could be, of course, as we have in Germany, inpatient program for a non-pharmacological treatment, what we call then neurorehabilitation. We have a rather structured and dedicated programs and even clinics in Germany, as I lead a clinic of about 300 beds or patients. So where you have then the program from week to week, which means here week 1, week 2, week 3, and then trying to apply these impairment-based therapies in these patients. Beyond the aspect of the specific disease, much more tailored to the specific impairment, which is, I think, the best way to get out and to have a better outcome and reach out to these patients. And another idea is to exemplify this in Pompe's disease. You will know that Pompe's disease is a very rare disease, but we have, it's one of the first myopathies where we had biology and genetically based therapy with enzyme therapy. And we see that in the last years with coming up the enzyme replacement therapies, also rehabilitation programs for Pompe's disease developed and developed a lot. So you see here in the last 10 years, we had a much more field of rehabilitation papers for Pompe's disease. And also here, I want to exemplify the aspect of impairment-based therapy. So you see here the patient with this hip girdle, limb girdle, and hip girdle weakness. So you see this kind of Duchenne maneuver of the adult. This is actually to show here to show here the breathing aspects of Pompe's disease. So respiratory weakness, and also here in the shoulder girdle muscles, here the scapular winning as an aspect of shoulder girdle weakness. So actually, we have on the one hand impairment of standing and gait, stair climbing. You will have the impairment of respiratory disturbance, and you will also have the impairment of arm function and weakened elevation of the arms, weakened or less endurance in doing a work over overhead with the arms. So actually 3 different impairments which have to be seen and recognized, and then the treatment has to be figured out, dedicated and tailored to this impairment. And we know that the patients, if you do qualitative interviews to improve patient-reported outcome measures, for example, in Pompe disease, we know that there is a lot of literature in the meanwhile, figuring out what is the most important aspect for patients. And as it turned out, that especially the last year's developments on patient-reported outcomes becomes much more important, because especially here, you will better see and more easily see in how far the impairment does really correlate to a function and disturbed function in Pompe patient. And for that reason, I think I just wanted to stress how important it really is to get a clue out of these aspects. And when I just some of these. Okay, so and when we now look on what is important for patient, and if we try to think about non-pharmacological treatment, we sometimes are surprised that possibly that what we as physicians treating people see at the most important aspects could be different in the patient's view. And you see here, for example, fatigue is for the patient of LOPD much more important than muscle weakness. On the other hand, we as physicians, and we would maybe when I will ask you, so if I ask you, so what is the most important aspect in Pompe? Possibly most of you will firstly think of muscle weakness, but we see that nearly 1/3 of the patients, more than 1/3, pronounce more the aspect of fatigue. And now the question is how, for example, tailor the impairment fatigue, the therapy on the impairment fatigue as similar for pain. So what is important here is, on the one hand, as you learned, so we can see by patient examination, by looking at the patients very precisely, that impairment can be defined by the physicians. But on the other hand, impairment could also be that aspects like fatigue and pain are aspects, impairments of patients which have to be taken into account. And this is actually what I wanted to figure out with this example, with this paper. So where we see that possibly it can be different what we see, what the patient sees, but actually we will just be successful in non-pharmacologic therapies if we hear on the patient's voice. So this is very important. You see also that we maybe as physicians would say that shortness of breath during activities is very important for the patient, which is still, it is nearly 60%. But in the overall, fatigue is a much more prominent symptom for the patient, which is actually an impairment which has to be focused maybe before we think about shortness of breath. So, but on the other hand, if we now try to look, so how should we, for example, aspects of breathing, of all these breathing respiratory disturbance in Pompe disease, we also have to face that we must know what therapies are available. So on the one hand here, for respiratory protocols of LOPD patients, we can say that there are different aspects which can be maybe undergo therapeutical approaches. So on the one hand, the conditioning, the lung recruitment, peripheral secretion hygiene, for example, nocturnal hypoventilation correction. So we have different aspects, even just looking on the aspects of breathing, where we need to apply different therapy approaches. So which is very important. So which also means that just if you possibly have one impairment like breathing disturbance, you should need you need to know what is the proper therapy to apply by having in mind that you want to improve impairment. And for that reason, I always stress that, for example, especially when you look for breathing improvement and improving breathing disturbance, there is, in the meanwhile, rather a lot of literature showing that, for example, if you just try to improve breathing by breathing therapy, like forced expiratory power, something like this, it was shown very clearly some years before that the combination of aerobic endurance training in combination with respiratory training gives the best result. And on the one hand, with aerobic endurance training, you on the one hand improve muscle positioning, muscle strength, especially the proximal muscle, but on the other hand, you also need to know that this can help to improve respiration at all. And if you try then to combine it, for example, with locomotor training, with treadmill, then you will have the highest effect out of these therapies. So, like exemplified here by examples from our clinic. So this, if you combine this with respiration training, you will have the best readout. On the other hand, you could also think about, if you are thinking about non-pharmacological training, and this is one of the most difficult aspects, so really to standardize treatment non-pharmacologically. So we know that in a muscle disease, you will have different stages where you start. So actually, a patient with pompe disorder, for example, in the very early or the slight symptoms is a totally different of a patient who has been suffering from pompe maybe the last 15, 20 years, so with much more severe symptoms. For that reason, it is, of course, difficult to have really one fits all a solution, which will not work. So you need to have a kind of standardized protocol, which is individualized for each patient, which, for example, put here a combination of aerobic exercise, passive stretching, resistant training, and then followed by a special cool down. And the way you do it is then has to be tailored individually on each personal situation. So that's the reason why I think one can say that rehabilitation and non-pharmacological treatment in neuromuscular disorders and myopathies is always a wonderful example and mirrors the need of individualized, personalized medicine on the basis of general aspects like impairment-based therapy, on the distribution of paresis, and on the stage of disease. This is also maybe here an example for whole body vibration, so which is also non-pharmacological in the last years to be shown for several indications, possibly helpful for muscle strength and also for endurance. If you combine this with physiotherapy, this is one of the aspects which could support gait, endurance, stability, and overall function, and beyond from all the aspects of quality of life aspects, which most of these studies show that patients really have benefit from these aspects also with regard to their life quality. And from that, then, this is actually maybe also the advantage of non-pharmacological treatment. So in the end, when we are talking about personalized medicine and tailored impairment based treatment, we know that we could then try to be creative and enlarge the programs, possibly 1 year, 2 years. As here was shown, that we can show that, for example, whole body vibration combined with endurance training can be a treatment from at least 1 or 2 years without any any dangerous side effects. So this was actually what I wanted to talk about: impairment to skeletal muscle function, skeletal muscle rehabilitation, application of non-pharmacological treatment on these aspects seen with regard to the specific impairment of a patient. And I already touched a bit the aspect of disturbed breathing. So in many myopathies, as in other neuromuscular disorders, we have the aspect of impaired disturbed breathing, respiratory aspects of breathing. So we know that before we focus, and I again stick to LOPD because it's such a wonderful example to show different aspects of impairment. And if I go to the respiratory impairment in LOPD, we on the one hand know that from a clinical situation we can judge about the respiratory situation, but we also have respiratory function tests, so like the pulmonary function tests, like forced vital capacity, improving pica flow, strength of respiratory muscles with maximal inspiratory and expiratory pressures to measure them, but also the competence of glottis in the cuff. So by coughing devices, measurement of oxygen during night, blood gas analysis, and don't forget that in many of the respiratory aspects of myopathies, we see that CO2 is of much more importance to know and to measure than O2 due to figure out all cases of nocturnal hypoventilation, which is actually mirrored by the CO2 situation during night, and of course in the later stages of disease during day. And from other groups, for example, like the group from Stefan Benninger in Munich, near close to my clinic here in southern Bavaria, they showed very nicely that if you do also in this diseased respiratory system of a LOPD patient, if you apply forced expiratory training, then you can improve the pressures you can build up, patients can build up, measured by maximal inspiratory pressures. And it is also shown that the maximal inspiratory pressures may also improve. That was shown by others also, not just by the Benninger group. So actually, you see that also breathing training in muscle disorders like LOPD, but this is actually just an example for others, could be also exemplified by several limb girdle muscular dystrophies. We do not really know at the moment if the neurogenic muscle atrophies like SMA, ALS, and maybe also axonal neuropathy show similar results due to breathing training as here in LOPD. But there is some aspects which is different due to the neurogenic atrophy in correlation and with the muscular aspects as in LOPD. And so which therapies are applicable then for patients with proximal myopathies like LOPD that can, of course, aspects like air stacking, inspiratory and expiratory stacking, then, of course, maximal acquired power, which can be treatments. And one which is, of course, of utmost importance is actually the resistance training, powered and forceful and expiratory training in these patients. And when I'm talking about this, on the other hand, you all will have asked yourself, but there are, of course, questions. So I talk very generally, but we know that on the one hand, we really have to look on the physical activities. So we know that there is a high clinical and functional heterogeneity in neuromuscular disorders, here exemplified in LOPD. We know do not know which individual patient this really has the best benefit out of what kind of therapy. Here is still a lot of things to be done to try to figure out programs with specific aspects in this specific stage of the disease, which is very complicated. So then on the other, no, we do not know what are the best outcomes, just exemplifying. So what is the best outcome parameter to for respiratory training? Is it maximal inspiratory pressure? Is it maximal expiratory pressure? Is it coming back to forced vital capacity, or do we have to think about other outcome measures in this aspect? And there are always discussions about the validity of these measures, the reproducibility of these measures, and it's not just from a clinical aspect, but also from a scientific aspect. We know that also clinical studies ran into negative results due to the inappropriate outcome measure. So it means that we have to think about much more harmonizing and structuring which outcome measure in respiratory disease or disturbance in neuromuscular disorders mirrors us really the improvement of a situation after applying non-pharmacological treatment like respiratory training. Another aspect is what we have to think about, that we on the one hand have the muscular function, as I was telling in the beginning, then about respiratory training, but what about other aspects? As you maybe remember in the composite group that we had pain as one of a very important aspect of LOPD. So if we think about non-pharmacological treatment in patients with myopathy, we have to be aware that we may have symptoms which could also be addressed specifically, like pain. On the one hand, we have pharmacological treatment of patients suffering from pain in myopathies, but we all know that's not that easy. And on the other hand, we know that possibly, for example, physiotherapy, sport therapies, aerobic endurance training can also improve pain. And we know that pain has a high impact not just in LOPD, in late onset patients, Pompe's disease, on the aspects of depression. So depression is closely related to pain intensity. For that reason, the better we improve pain, the less risk the patient has to get or develop, or even to have a worsened depression. And for that reason, we also know that muscle pain correlates very well with anxiety and depression. So in the end, reducing muscle pain could also result in reducing anxiety and depressive symptoms in this disorder. For that reason, we have to account that all we do with physiotherapy, with sport therapy, does in the end could also aim on reduction of pain, although at the moment we do not have we have not enough clinical studies with evidence level 1 or 2 to prove that. But from a clinical point of issue, for me as a rehabilitation doctor, we see it so often that very often also in neuromuscular disorders, if you address muscle activity, for example, back pain, and can be reduced just by muscle strength improvement and back muscles, which can reduce pain and consecutively also correlates with reduced anxiety and depression, as it was shown in this work from the Bochum. So if we you saw, and I tick a bit to this fatigue aspect, because fatigue is not just Pompe specific. We know that many other myopathies, especially myopathies, but also neurogenic muscular atrophies like Charcot-Marie-Tooth disease, have the aspect of fatigue. Fatigue, and we learned a lot in the last years about fatigue. For example, in our clinic, we have a fatigue group, and the fatigue group, there are patients suffering from post-COVID, from neuromuscular disorders, from multiple sclerosis, because fatigue is possibly one of the last end of a long multifactorial aspect of somatic aspects running, and psychological aspects running into the symptom of fatigue. So the fatigue model, for example, also I exemplified here with LOPD, is actually on the one hand, you have disturbed body function, you have disturbed activity and capacity and performance, and so actually you have a reduced participation, which is actually on the one hand is a kind of physiological fatigue, experience fatigue, which then ends in the overall what we call fatigue, although knowing that measuring fatigue is actually not that trivial, because we have a lot of different fatigue scales, and we sometimes have to ask ourselves if does the applied scale really measure fatigue, or does it mean, for example, does it measure aspects of depression, inactivity, or sleepiness? But as we see here, others, fatigue is a prevalent. I always stick to Pompe, but you see here myasthenia gravis, Guillain-Barré syndrome. So we have diseases where we have fatigue as a very prominent symptom. So how to, and on the further we know that in diseases like Pompe, we see that progression and development of fatigue does, on the one hand, is dependent on sleep quality, but also on the severity of the disease per se. And I skip this. And on the one hand, we know that fatigue can be also be impacted by proper peak treatment, but this is quite nicely shown here in this group, so that aerobic endurance training can reduce pain and fatigue. So for that reason, and there we have good literature from the last years. So the less patients do physically, the less they do endurance training, the more pain and fatigue they develop. And on the other way around, so we know that aerobic endurance training has quite an impact on reducing fatigue and pain significantly in patients with myopathy, so which was shown in this rehabilitation paper very nicely. So the evidence of rehabilitation, just to show this is not that easy, because actually, so the evidence for rehabilitation in neuromuscular disorders is, of course, dependent on the quality of studies. And you will know that the Cochrane approach is somewhat is not ideal for patients with neuromuscular disorders, because we know that we mostly have not these big groups of cohorts on the one hand. So we have different stages of disease, making it much more different, especially under the Cochrane criteria, to find enough evidence, grade 1 or 2, for rehabilitation in neuromuscular disorders. But we know that at least, so it was shown, for example, here in the group from Nicole de Voet in the Netherlands. So if we look for aspects like aerobic exercise, strength training, so for example, here of a good dermatomyositis and other muscular disorders, so that we see that applying and different aspects of endurance training has a positive effect on pain and fatigue in, for example, here in dermatomyositis. And we know in the last years, more and more of these meta-analyses come up, and we have also, in the meanwhile, enough evidence that strength training in some myopathy is effective and beneficial. For maybe neurogenic neuromuscular disorders, the evidence is still lacking. And because we know that, for example, in amyotrophic lateral sclerosis, it's even worse and even more difficult to show evidence here because disease is so variable. So in the last 2 minutes, 5 minutes, I want to stick how to classify actually what we think is improvement. So on the one hand, we look for the aspects of all what we call the whole problem, the overall problem. So the international classification of function and disability is one of the very important aspects to figure out and to tailor dedicated therapies, non-pharmacological therapies. So I have here a wonderful paper where it is figured out which dimensions of function actually are impacted by a patient with ALS. So on the one hand, we know that there's especially aspects like communication, movement, personal care, and daily activities and social life being affected by the disease. So if we look for a proper therapy, as I said, impairment-based it should be, and on the other hand, we have to look in more aspects, not just impairment, but also functioning, disability, and health. And there we see that we need to look for different dimensions of these aspects. As I said, communication, movement, personal care, interaction with people, daily activities, and social life. And then we can, if we do it here on a scientific basis, we can look for severely, moderately, and slightly affected aspects. And we will see that here we get these kind of individual fingerprints. And so our therapy should be tailored to this. And just here, this example of a woman affected or suffering from ALS, she herself had this self-construction just to raise and to get functioning of her arms by improving this by using kind of aspect to lift her hand. We know that there are much more modern aspects, but this is actually how the patient did it at her home. She showed us just to have the function of having something, using her hand to bring something to her mouth. So, which is here also impairment, but also functioning. So beyond impairment, we have functioning, which is actually so the content of the classification of functioning, which is for me in a rehabilitation clinic actually the basis to tailor the therapies, the non-pharmacological therapies, having in mind the aspects of the impairment, which leads into dysfunction of a limb or a body function. So, for example, just here one of our consideration of ICF. If you see this patient, this was a patient with severe CMT and also additionally suffering from a toxic shock syndrome with amputation. But you see walking, stability, gait function was here actually an aspect which was tailored to this patient. And in the end, we could improve participation, we could improve mobilization, just non-pharmacological with the application of physiotherapy, occupational therapy, and specific, of course, of specific orthesis to make the patient bringing back to the best participation he could get with all this, severe diseases actually in the combination. So in the end, I tried to show you, on the one hand, the kind of aspects, translation, basic knowledge into application. I tried to figure out impairment, the impairment based approach. So independent from the disease, trying to figure out what is the impairment, actually with specific regard to muscle function, to specific aspects in CMT and Pompe, but this exemplifying on the one hand neurogenic and myogenic neuromuscular disorders with a specific aspect of breathing. So trying what is applicable for respiratory improvement. And in the end, I wanted to show you just to bring your scope to the aspects of that impairment always will be seen also or will be mirrored in the international classification of functioning. And I thank you, and it was possibly much more an aspect to open your mind to these aspects of non-pharmacological than giving you precise instructions, what is the best for which disease, because as I said, this has to be seen in an individual way based on the impairment and the international classification of functioning. Thank you. And for all whom are interested where I am, I'm in the very south of Munich, but Feinbach, we run here a rehabilitation clinic with a center with 300 beds with a specific unit for neuromuscular rehabilitation. Thank you for your attention.
Thank you very much, Professor Young, for this interesting presentation. It was very complete. So thank you for being with us today. So we are waiting for questions from the audience. Don't hesitate. It's now or never. You can write your question in the Q&A, or you can also write in the chat, or you may also voice your question if you want. Just raise your hand.
Oh, it doesn't seem to have any questions left.
Yeah.
or even maybe. So, but everybody who is interested in rehabilitation then can also write me an email. You will find me very easily on the internet. So if you have special aspects, and I know that it's very different in different countries in how far rehabilitation, non-pharmacological treatments could be applied. So this is also maybe very different in different countries.
Yes. Thank you very much, Professor, for your time, for being with us today. I hope maybe to see you again in another series of webinars.
Yes.
You will be always welcome. So thank you very much.
So it was a pleasure. So I hope everybody has a nice afternoon and enjoyed my talk. So see you possibly once again.
Thank you, Professor. Goodbye.
Elizabeth. Thank you for
Bye.
organizing. Thank you. Bye.